just called platelet poisoning, and it's a case of Plavix that I just kind of wanted to go through with you some of the tricks of monitoring Plavix treatment. This was a 42-year-old woman who developed a sudden onset of right facial numbness, slurred speech, upper extremity weakness, and numbness and tingling of her right fingers. She had stopped taking her aspirin 3 weeks before because she saw something on TV that said aspirin might cause her to have a gastrointestinal hemorrhage. And her daughter said that she'd actually noticed the patient was having more of an unsteady gait for like the last 3 months. And she also had a several-year history of hypertension. They did a CT scan of her head, and it showed 2 old areas of cerebral infarct in the parietal and the frontal lobe. An MRI showed that she had an infarct, sort of a subacute infarct, in sort of the external carotid and the middle carotid artery areas, and there was no evidence of an acute bleed. An MRA showed that she had 90% stenosis of her left internal carotid artery. So at that point, it was decided that the radiology interventionalist should go in and stent this internal carotid artery. And she had a very good neurological response afterwards. And once he completed the stent placement, he started her on Plavix post-operatively. And this just kind of illustrates what happened is your common carotid artery, your internal carotid, and your external carotid, and she was actually having occlusion of this internal carotid artery and was having plaque buildup and narrowing of that blood vessel. And so they went in then and actually inserted the stent and dilated out that artery. But because you do have this foreign surface in here now, platelets are very prone to stick to that, and so you want to inhibit platelet function afterwards, and that's why we're using Plavix. Well, Plavix is actually a prodrug. It's not active itself. It has to be metabolized to the active drug. And it's metabolized by the enzyme system called the cytochrome P450 system, and specifically it's the CYP2C19 enzyme that metabolizes it. The active metabolite binds to the platelet receptor and inhibits the ADP signaling that results in platelet aggregation. And so by giving Plavix, you can prevent platelet aggregation and blood clot formation. The bad news with this drug is that studies have shown that about 40% of patients have variant genes of this CYP2C19, and they don't metabolize this drug as rapidly. And then there was a couple of interesting studies in the cardiovascular literature that showed that if patients get good inhibition of their platelets by Plavix, they have a very low incidence of death or myocardial infarction up to 1 year after stent placement. But if their platelets aren't inhibited because they have one of these variant genes, they have almost a 6-fold higher incidence of death or myocardial infarction simply because those platelets are able to still form blood clots. So the FDA, when they saw this data, they put another black box warning on Plavix. And they talked about how a large percent of the population are poor metabolizers, and those patients are at higher risk of having events after stents. And that they also put in their black box warning that tests are available to identify a patient's CYP2C19 genotype, and these tests can be used as an aid in determining therapeutic strategy. I thought it was interesting that they specifically mentioned genotype because at the time this came out, there were no FDA-approved tests for doing genotyping, and Medicare nor any other insurers would pay for it. So we looked at this. The cardiologist had asked us to look into offering some type of testing because they felt liable, knowing that such a large percent of the patients weren't responding to the Plavix. And when we looked into this, we found that the instruments to do genotyping cost anywhere from $100,000 to $250,000 a piece. The cardiologist wanted to be able to test these patients at all the different metro hospitals, and so it was impractical to have this kind of instrumentation even at the smaller hospitals. It would cost about $400 per test to do the genotyping, we would only get reimbursed $200 per test, so we're going to lose almost $300 every time we did the test. And it took more than two days to get the results. But we did find you could also test for response to Plavix by actually doing platelet function testing. And this testing was less expensive, the instruments were less expensive, and even though it would cost us about $50 to do the test, but and Medicare was paying about $60, so you weren't going to make any money on this test, but you weren't going to lose your socks either. So back to our case study, the day after this patient had their stent and got Plavix, they were loaded with Plavix, and the doctor ordered a PFA 100, which is another type of platelet function test that we do in the laboratory. And this was the test that he was used to ordering at the hospital he practiced at before he came to St. Luke's. And he was dismayed because even though he'd given her a large dose of Plavix, the results came back and suggested that she just had very mild inhibition of her platelet function. So the next day he gave her another loading dose and then increased her dosing to twice a day, ordered another platelet function test a couple days later, and it was normal. So at that point he called one of the pathologists and asked, what's going on with your instrumentation? I'm not getting any indication that the platelets are being inhibited. And we explained to him at that time, well, this test won't detect Plavix inhibition of platelets. It doesn't work for that. And so we suggested that we test this patient with this new instrument called Verify Now that we had in the laboratory that's specifically used to test for Plavix function. And this is really a little point-of-care type instrument. It uses a disposable cartridge. You have separate cartridges for aspirin effect, for the 2B3A inhibitors like integralin, or for Plavix. We were just using it for the Plavix effect. You just put a whole blood sample. You draw a whole blood sample, and then you insert it into a cartridge that goes into this instrument. It aspirates the whole blood out, runs it through these channels, and mixes it with the different agents that are needed to test for the Plavix effect. And the whole basis of this instrument is that if platelets are functioning normally, you don't have much space between the beads or the platelets that they have in this assay, and so you get low light transmission. But if the platelets are functioning normally, they aggregate together, and so you do get a lot of light transmission. But if they're inhibited by the Plavix, everything is spread out, and you don't get good light transmission through this field. And so by looking at the amount of light transmission, you can tell whether or not the platelets are being inhibited by the Plavix. The units that we report out are called PRUs. That stands for the P2Y12, which is the actual receptor of the platelet being inhibited by the Plavix. They're called P2Y12 reaction units. People that are responding to Plavix have a PRU number of less than 200. Those that are high risk of having a thrombosis have a PRU value of greater than 230. And these patients then need to be either treated with a higher dose of Plavix or switch to another drug like prasugrel. You can also calculate out what % inhibition is occurring, and people that have that less than 30% of their platelets are inhibited are at high risk of having thrombosis. This also can be used to determine if a patient can go to surgery that's on Plavix, and if the inhibition is less than 20%, it's unlikely that they're going to have increased bleeding during surgery. So in our patient, in this case, the PRU came back 135, the baseline was 246, so they had 45% inhibition. So this patient was getting an adequate dose of Plavix and shouldn't have any problem with thrombosis of the stent. So in summary, this was a patient who responded well to treatment. She had a little bit of decreased vision in her left eye that might have been due to an embolus to the ophthalmic artery. But other than that, she was able to be discharged to outpatient rehab. She was maintained on Plavix for 3 weeks, twice a day, and then switched to 1 tablet per day. She was just followed up with her primary care physician, and the last time I checked with him,